Good afternoon. My name is Stephen Poplack. I'm a breast radiologist at Stanford University in Palo Alto, California. I want to thank the committee for allowing me the opportunity to present our work on the prospective assessment of ultrasound guided diffuse optical tomography in women undergoing breast biopsy and its impact on BI-RADS assessment. I have no financial disclosures. The study receives funding from the National Cancer Institute, which is ongoing. I'd like to acknowledge our exceptional research team, and in particular, Dr. Qing Zhu, PhD, who is the developer of this DOT prototype. To give you some context, one of the biggest problems with breast imaging is the overlap in imaging appearance of benign and malignant entities. So on the two slides to your left, two images to your left, these are two different cases that appear very similar. One on top is an invasive ductal carcinoma, mucinous subtype, and the other is a fibroadenoma. This is one of the key problems we have in breast radiology. Furthermore, most positive assessments are low to moderate suspicion, at least in the USA. One large study showed nearly 80% of positive assessments to be either low suspicion or moderate suspicion. Furthermore, the positive predictive value of biopsy of low and moderate suspicion lesions is low, and that occurs worldwide. Here are 4 different studies from across the globe showing PPV3s of 15% for 4A assessments and 43% for 4B assessments. And lastly, the risk of a false positive biopsy is substantial. From the European group, estimated almost 3% false positive biopsy rate on the order of 10 biennial screens in women in their 50 to 69-year-old range. To give you background on diffuse optical tomography, it involves the transmission of near-infrared light at specified wavelengths that are selectively absorbed by chromophores in tissue, namely water, fat, oxygenated, and deoxygenated hemoglobin. This allows us to quantify total hemoglobin content in tissue, which is the sum of deoxy and oxyhemoglobin. And total hemoglobin reflects tissue vascular content, which is analogous, we think, to other vascular-based imaging, like contrast-enhanced MRI. Total hemoglobin varies by lesion histology. It's elevated in breast cancer and decreased in benign histology. Ultrasound Guided Dot is a combination of a commercial ultrasound transducer and a prototype DOT device. We use the standard of care ultrasound to localize the lesion, and that allows for a more accurate, enhanced reconstruction of optical properties. We also scan the mirror image contralateral breast to normalize the background optical properties. The reconstruction is performed offline and generates numeric total hemoglobin values as well as maps total hemoglobin spatially. Here's a representative example in a patient with a maximum total hemoglobin of 111 micromolar, and you can see the spatial map bottom right. This is the kind of data, these are the kind of data that were given to our radiologists when interpreting the combined ultrasound, DOT, and conventional imaging. Here's a look at our prototype commercial transducer, the array that is now open, the optical fibers emitting near-infrared light at specified wavelengths. These black cables are the light guides for the detector fibers. Here's the closed array and the business end of the device showing you the commercial transducer, the emitter and detector fibers, and the rather large 9-centimeter footprint. Getting back to the study, this was a prospective HIPAA-compliant study which required informed consent. Women were eligible if they were 18 years or older or referred for ultrasound-guided core biopsy or diagnostic FNA. The vast majority, or 59 of the 61 patients, had core biopsy and 2 had diagnostic aspiration. In the US, core biopsy is the overwhelming technique used. There were significant exclusion criteria which aimed at excluding conditions that altered breast vascularity, made the DOT exam more feasible, excluded confounding additional lesions in the area of the abnormality of interest, and also excluded lesions where the contralateral breast had an abnormality, which would perturb the background reference information. On the day of exam, we did a targeted ultrasound, which took about 5 minutes, then performed the ultrasound guided DOT, which took 5 to 10 minutes. That's 8 to 10 data sets of the lesion and about 5 data sets of the contralateral reference breast, and then the biopsy was performed. The radiologist performing the biopsy was not allowed to interpret the DOT study. They were precluded from that. Also, readers were blinded to pathology, of course. In terms of pathology, a primary diagnosis was abstracted by our study pathologist, and benign lesions were subcategorized into proliferative, non-proliferative, and fibroadenoma-like lesions. In terms of the reader study, and exam interpretation involved 4 study radiologists. These were academic breast imagers, spent 100% of their time doing breast imaging. They were very experienced, a mean of 22 years of breast imaging experience. And we did have a training session prior to the first batch reading session that went over ultrasound DOT exam interpretation. Here are some of the highlights from the training presentation, which stressed maximum total hemoglobin numeric values with thresholds of 50 micromolar or less being typically benign and greater than or equal to 80 micromolar being typically malignant. We also described how to code spatial map features of shape, location of highest hemoglobin, either central or peripheral, and the ring distribution, either tight or loose. Here's an example of DOT data that was given to the radiologist at the time of the study interpretation. And here you can see typical background, very little color or hemoglobin in the area, a more benign appearance and a more malignant appearance. The sequence for reading for each reader: first confirmed the patient and lesion information. They then reviewed the clinical information and breast imaging exams and reports and entered an exam report BI-RADS. That was based on the clinical report. They then reinterpreted the conventional breast imaging and provided a conventional imaging BI-RADS based on their own study read. They then reviewed the DOT data, which I've shown you, the format. They recorded hemoglobin concentration. We wanted to keep that front and center for our readers. They evaluated the spatial maps. If it was background only, they skipped this section. If it was more than background, they filled in the different features. And finally, they entered an integrated BI-RADS, including both conventional imaging and diffuse optical tomography data. And lastly, noted any change in the BI-RADS assessment from the study read to the CI and DOT read. In terms of results, there were 127 eligible patients based on the exclusion criteria I've mentioned. About half declined participation. Of the remaining 63, 1 was excluded because their biopsy was not performed. It was canceled. It was felt not to be warranted. That left 62 patients. 1 patient was excluded because of corrupt DOT data. It was a very large superficial lesion that deformed the skin, and the contact with the DOT probe was insufficient. And that left us with our study group of 61 patients with 15 malignancies and 46 benign lesions. Cancers were significantly larger than benign lesions. However, when we did an ROC analysis, total hemoglobin was more predictive of cancer than size, and that trended, though was not statistically significant. Here's a look at, just looking at numeric total hemoglobin, there was a statistical difference between cancer and all benign lesions, an even larger difference between cancer and non-proliferative benign lesions, and a difference between cancer and fibroadenoma-like lesions. There was no statistical difference between cancer and proliferative lesions. We also did an ROC analysis to arrive at the optimal point on the ROC curve, the optimum pair of sensitivity and specificity, and that value is a total hemoglobin of 78.5 micromolar, which gave a sensitivity of 80% and a specificity of 88%, I believe. This shows the characteristics of 15 patients with cancer. You can see that 2 of those 15 patients did have downgrades, although their downgrades were not clinically significant because biopsy was still recommended. You can see a common theme that the total hemoglobin was low, and of interest, they were somewhat unusual histologies, an invasive lobular carcinoma and an invasive papillary carcinoma. Here's a look at the false positive when using a cutoff of 80 micromolar, 2 fibroadenomas, a papilloma with atypia, papillary apocrine metaplasia, and a complex sclerosing lesion. And these are the type of false positives that we see when we do MRI guided biopsy. For those breast radiologists performing that, I'm sure you're quite familiar. This is the crux of the study, and it shows the impact of DOT, adjunctive DOT, on BI-RADS assessment. And we showed that it decreased false positives by 23.5% overall and 38% for low suspicion assessments. You can see for all comers, 132 had false positive, and then with DOT went down 101. There was a range based on reader. Reader 1 and 2 had the least reduction. They were also the least experienced with the technology. Readers 3 and 4 were experienced with DOT, but had not performed any DOT interpretation. Perhaps these readers were more confident in the technology. Here's an example of a case that was appropriately downgraded and where I think this technology will have its greatest benefit. It's an indeterminate hypoechoic lesion in a young woman with a palpable abnormality, and you can see that the hemoglobin is at background, and 3 of 4 readers downgraded this to a non-actionable BI-RADS. In discussion, this really shows the potential to reduce benign biopsy rate. We don't have any intention to downgrade very suspicious lesions. We know that the positive predictive value of 4C and 5 assessments is really too high to want to approach those assessments. But most of the suspicious assessments are low to moderate. So we're going to have quite a few patients who are amenable to this kind of adjunctive technology. It is an attractive technology. There are no known health risks. It's inexpensive. There's a rapid acquisition time. Gives you vascular information without intravenous contrast. Easily integrated into the clinical workflow. Has a fast learning curve. And we may expect improvement with experience. Our results are comparable to other adjunctive ultrasound technologies like shear wave elastography and photoacoustic imaging. I will note, however, that this is a small pilot, and the studies I'm reporting here are large multi-center trials. In terms of shear wave elastography, there was a 33% downgrade of 4A lesions without false negative. We showed a 38% 4A without false negative. Photoacoustic imaging had a larger downgrade rate, but an unacceptable downgrade of malignancy. We had many limitations. There was a small sample size. The size of the cancers were pretty large, so we know from the experience of standalone diffuse optical tomography that there was a size limit of about 6 millimeters. We think that the combination of ultrasound DOT will mitigate that, but we don't know that. Also, we don't know if this is generalizable. The readers in the study were very experienced breast imagers, and there were extensive exclusion criteria. And also, the lengthy reconstruction time would preclude its contemporaneous use in the clinic. So in conclusion, adjunctive ultrasound guided DOT led to a 23.5% reduction in false positives overall and a 38% reduction in false positive 4A assessments. There was no downgrade of cancer to a non-biopsy recommendation. It seems to have its greatest impact on non-proliferative benign histology. Absolutely requires validation in a larger trial with more lax exclusion criteria. But I think that this is an important problem in breast cancer screening and diagnosis, and having a technology that improves our positive predictive value stands to benefit patients individually and society at large. I want to thank you for your attention.